Hello everyone. Second week of May is observed worldwide as the Retinoblastoma Awareness Week to promote early detection and initiation of treatment for its intraocular malignancy to improve the ocular outcomes as well as overall survival for these patients. I'm Dr. Sonal Yadav, practicing ophthalmic plastic surgeon and ocular oncologist from Pune. Retinoblastoma indeed is a vast topic. However, in the following presentations, I will try to give a comprehensive review of the topic. As we all know, it is the most common primary intraocular malignancy in children aging from newborn to around 6 years of age. 1 as to 15 to 18,000 live births remains the incidence. The disease can be both unilateral as well as bilateral. And this will be a two-part video series. We'll talk about genetics, pathology, and clinical features in the first presentation, while management will be covered in the following video. Loss or inactivation of both alleles of PRB gene is important in tumorigenesis of retinoblastoma. As described in Knudsen's two-hit hypothesis, the timing of the first hit decides the pattern of inheritance. Either it is preconceptional or happening after birth. The second mutation is generally occurring after birth. Though the two hits are commonly described, the M3 or the third event involving genetic instability or epigenetic modification is also important in the genetic makeup of retinoblastoma. The tumor varies from poorly differentiated to well-differentiated cells. The classically described rosettes and florets are seen more in the well-differentiated tumors. Talking about clinical features, leukocoria or the white eye reflex or cat's eye reflex is the most common presenting feature, followed by strabismus, red painful eye, and poor vision. Here is an example of leukocoria or a white eye reflex in the left eye of the child, easily seen with a flash photography. Esotropia because of the tumor in the left eye, red painful eye, which is most commonly presented because of advanced nature of the tumor, tumor necrosis because of untreated advanced intraocular tumor, can also present with orbital cellulitis, ifema. When the tumor can no longer be contained intraocularly, frank extraocular extension is presented as proptosis or an orbital mass. It is very important to know about the differential diagnosis of leukocoria. There are a variety of conditions which mimic the white eye reflex. These can be congenital and developmental anomalies, vascular pathologies, inflammatory or infectious diseases, other neoplastic conditions, etc. It's very important to differentiate these from retinoblastoma as the line of management changes drastically for these diseases as against retinoblastoma. For example, persistent fetal vasculature, Coats disease, retinopathy of prematurity, ocular toxoplasmosis, choroidal colobomas, or endophthalmitis are few of the differential diagnoses of leukocoria. Retinoblastoma tumor starts as a small, white, fluffy lesion in the subretinal space. The direction in which the tumor grows decides the growth pattern, either endophytic when the tumor grows into anterior vitreous cavity, exophytic if the tumor grows below the retinal surface in the subretinal space. Mixed endophytic and exophytic pattern is the most commonly observed growth pattern of retinoblastoma tumor. Diffuse infiltrative is a tricky growth pattern of retinoblastoma tumor where there is no frank intraocular mass seen. However, placoid lesions of the retina are the manifestation of the tumor. This is an example of frank extraocular or orbital spread of retinoblastoma. In a suspected case of retinoblastoma, a systematic stepwise approach to involve detailed history taking, initial in-office examination, ultrasound B scan, EUA and ancillary testing can provide a diagnosis of retinoblastoma in around 90% of the cases, which is then followed by neuroimaging, followed by counseling of parents regarding the nature of the tumor, genetics and other aspects, and available therapeutic options. A detailed history taking involving the birth history, prior consultations and procedure history, and family history is essential. Ultrasound B scan is a relatively inexpensive, easily available, non-invasive investigative modality which can provide a retinoblastoma diagnosis with ease because of the classical features of intraocular tumor mass with hyperreflective echoes because of intratumoral calcifications. The calcifications can also form orbital shadowing as seen over here. This is then followed by examination under anesthesia to note any external findings, for example, proptosis, orbital mass, or eyelid masses, followed by bilateral anterior segment examination and intraocular pressure documentation, followed by bilateral dilated fundus examination with scleral depression to examine the 360 degree of aura. Anterior segment examination covers the measurement of horizontal as well as vertical corneal diameter to rule out microphthalmos or ophthalmos in these eyes, followed by intraocular pressure measurements by Perkins tonometer. These are some of the variety of clinical signs seen in anterior segment examination. For example, presence of cataract in posterior synechiae, phthisis and scleral nodule, a generalized congestion with anterior chamber inflammation, presence of anterior chamber seeds, presence of iris neovascularization, and vitreous hemorrhage resulting in vitritis. A detailed posterior segment examination in case of retinoblastoma will give you an account of number, location, location and dimension of the tumor, along with associated features. For example, retinal detachment, presence of subretinal fluid, presence of vitreous seeds, or vitreous hemorrhage. Documentation either with fundus photographs using a RETCAM or a drawn color-coded diagram of fundus is very important at the initial as well as follow-up of these patients. Neuroimaging is advised in all patients of retinoblastoma, especially in cases to rule out atypical diagnosis, to confirm diagnosis with presence of intraocular calcification, to look for optic nerve involvement, to look for any extraocular extension, and to look for any posterior scleral contour abnormalities. On CT scan, the intratumoral calcification is seen as a hyperreflective shadow. On T1 weighted MR images, the tumor is seen as hyperintense, while hypointense on T2 weighted image. Abnormalities in the posterior scleral contour denotes choroidal invasion, while extrascleral extension like this can be seen, frankly, on MR images. A little bit about orbital retinoblastoma. When frank extraocular extension is detected at the time of primary consultation, it is termed as the primary orbital retinoblastoma. Secondary orbital retinoblastomas are when in an unsuspected eye, intraocular surgery has been carried out and the tumor is made extraocular, making it an accidental orbital retinoblastoma. Overt orbital retinoblastoma is when the extraocular extension is detected at a time of enucleation surgery in a case of presumed retinoblastoma. Microscopic orbital retinoblastoma is when the margins of resection of the enucleated eye are positive, making it a microscopic orbital retinoblastoma. So this completes the first part of my presentation. The second part will cover the management of retinoblastoma.